treats at the duodenojejunal flexure. Anything proximal to it is considered upper GI bleed, and all bleeding distal to that ligament of treats is considered lower GI bleed. I've covered adequately in the last lecture on upper GI bleed. Today, we shall talk about the lower GI bleed, which is bleeding from the DJ flexure right to the anorectal region, which consists of the small intestine, large intestine, rectum, and the anorectal region. Normally, the stools contain some amount of blood which is secreted or lost daily in the stools. It is estimated that 1.2 mils per day can be normal. The significant loss is when it reaches 10 mils per day. If there's a loss of 10 mils per day of blood in the stool, it is pathological and needs to be investigated. The most important presenting feature is hematochezia, which is actually fresh bleeding per rectal. It can be bright red if it is an arterial source and the bleeding can be brisk, or venous and the blood is dark in color or dark red in color. This diagram shows the setup of the lower gastrointestinal tract where the bleeding takes place. On the left, highlighted by this green ink here, are the 4 common causes from the small intestine and ascending colon. These include angiodysplasia in the right or ascending colon, diverticular, which is not so common, carcinoma of the cecum, which often presents as occult blood, and Meckel's diverticulum from the terminal ileum, which is more common in children and young adults as a source of lower GI bleed. On the left here, highlighted by this blue color here, are the 4 common causes of bleeding from the left side of the colon: ischemic colitis, carcinoma of the ascending colon, polyps of the descending colon, colonic diverticular involving the sigmoid, and at the terminal end of the rectum and the anal canal, you have solitary ulcer of the rectum, anal fissures, hemorrhoids, which are common, and inflammation of the rectum and the colon, which can be either Crohn's disease, ulcerative colitis, infective causes, or radiation colitis. I have to remind you that the important condition of dengue fever as a cause of lower GI bleed. This is especially so in children and young adults. In our country, where dengue is endemic, this condition should always arouse suspicion of the cause of bleeding. This table lists the common causes of lower GI bleeding according to the site. Colonic bleeding accounts for 95% of the bleeding cases, with diverticular disease, anorectal diseases, especially hemorrhoid, neoplastic lesions, polyps, and cancer, and angiodysplasia being the most common 4 conditions affecting as a cause of lower GI bleed. On the left, the smaller intestine contribute only 5% of the bleeding cases, and of interest is Meckel's diverticulum, which occurs in young adults and children, and in older individuals you have mesenteric ischemia. All the other causes do occur from time to time, but not so common. Common causes. These are the 5 most common causes of lower GI bleed in our country: diverticulosis, angiodysplasia, colorectal cancer, colitis of various causes, inflammatory cause, radiation, ischemic, and anorectal causes, especially hemorrhoids, cancer anus, fissure in anus, and even fistula in anus. Of course, as mentioned, dengue fever should not be forgotten as a common cause of GI bleeding in our patients. The low platelet count is an indicator of the possibility of passing stools with blood stain. Incidence by age group is another important source, or even important as a cause of diagnosis. Adolescents and adults, you have Meckel's diverticulum, inflammatory bowel disease, and polyps as the common causes in that age group. Adults to 60 years of age, the common causes include diverticular or diverticulosis of the colon, inflammatory bowel disease, and neoplasms. Whereas adults over the age of 60, the common causes are arteriovenous malformations such as angiodysplasia, colonic diverticula,
Okay, can you just read the, Nicole, just read the question.
Okay, hematochezia, the passage of gross blood from the rectum, usually indicates lower GI bleeding but may result from which of the following: bleeding from a source of the right colon, injection of bismuth, injection of supplemental iron, massive upper GI bleeding with rapid transit of blood through the intestine.
Okay, give you 30 seconds. Okay, we close. So, okay, the question asks you, hematochezia is the passage of gross blood from the rectum, indicates lower GI bleed. Okay, right colon is not lower GI bleed. That's why the answer is, although it is a cause of bleeding from there, but they're asking what else can be other than the lower GI tract. So this is the answer, the last one. I think majority, I think second group. Okay, massive GI bleed with rapid transit of blood through the intestine. So that's how in varices, esophageal varices and duodenal ulcer, when they bleed a lot, the blood is too much, so it comes out very fast, then the patient has also got fresh bleeding. So massive upper GI bleed can also present as a lower GI bleeding. That's why in many patients, if you cannot find the cause straight away, we also do a colonoscopy as well as a OGDS to rule out upper GI causes. Okay? Okay, now you continue.
What are the symptoms of the main symptom of lower GI bleed is bleeding in stools or passing blood in the stools. And this stool, passage of stool in these blood-stained stools, you must be able to differentiate the relationship of the bleeding to the defecation. It can be initial, which is before defecation, and in these cases are usually external causes: anal fissures, trauma to the perineal region, and abscesses around the anus. It can be terminal, that is bleeding occurring after defecation, which is classical of hemorrhoids. And most commonly, it is usually mixed with the stools. Okay, and this usually are the causes that occur higher up in the lower GI tract, especially in the sigmoid colon and descending colon and proximally. Usually they are due to tumors, vascular malformations, and polyps. Then you have to also look at the associated symptoms that come together with passing blood in the stools. Pain, which can be a common condition, a complement, colicky pain due to infection or skin lesions. Mixed with mucus, especially in inflammatory conditions, infection and tumors. Abdominal symptoms, especially cramping pain due to blood in the intestinal lumen, causing colicky abdominal pain. And symptoms related to the primary cause. Example, cancer, they tend to have constitutional symptoms of loss of weight and lethargy. This chart shows you the importance of taking a good history in coming to a diagnosis of the cause of lower GI bleeding. Hemorrhoids usually bleeds after defecation. Fresh blood drops on the stools. Sometimes frank spurting of the blood after defecation. Occasionally, it presents as a lump coming out of the anus due to the prolapse hemorrhoids, which causes perianal discomfort. Anal fissures, usually the blood, fresh blood, streaked on the stools. And the most important thing is associated with sharp pain, sometimes severe. You start with defecation and last for hours after that. Inflammatory bowel disease is classically blood, mucus, and diarrhea. Painless unless coexist fissure, and systemic symptoms may occur, like such as low-grade fever. Okay, now what are the physical signs? Physical signs can be external, related to these conditions, that can be easily excluded by local examination of the anal region. Perianal conditions, anal varix, thrombosed anal veins, fissures, and prolapsed bowels. Signs can also be related to the blood loss, like anemia, pallor, hypovolemia, abdominal distension, abdominal tenderness, and rectal examination, which in fact can exclude most of these conditions in most patients. And the signs can also be related to the primary cause of the bleeding. Abdominal mass, if it is a tumor that causes the bleeding. Tenderness and guarding, if it is diverticulitis causing the bleeding. If it is cancer, you can have loss of weight or emaciation. That's the signs indicating it is related to the investigations for lower GI bleeding. First, the routine investigations, which include chest X-ray, renal and liver function tests, ECG, and especially important is your hemoglobin and hematocrit and the coagulation studies, especially prothrombin time, clotting, and bleeding time, which are very important in such bleeding cases. Specific investigations include, most important, endoscopy. And the mainstay of investigation and treatment is colonoscopy. Okay, a colonoscopy is a must investigation for patients with lower GI bleeding. Sometimes upper endoscopy should also need to be done if you are unable to exclude upper GI bleeding as a cause. The next is your RBC scan. This is a radioisotope tagged RBC scan, which is done by withdrawing the blood from the patient, tagging his RBC with technetium-99 radioisotope, and then re-infusing this treated RBC into the patient and follow up with radioisotope scans over the abdomen. The important thing is the patient must be bleeding at a rate of 0.41 milliliters per minute. At this rate, then the test can be positive if there is a bleeding in the GIT. The next is angiogram. Angiogram is also the mainstay, is one of the important investigations for lower GI bleed. It can be either a CT angiogram or direct catheter angiogram. Angiogram is capable of detecting bleeds as low as 0.5 mils per minute. In order for the angiogram to be effective, the bleeding rate must be at least 0.5 mils per minute. Otherwise, it will be negative. Okay. The original direct catheter angiogram also gives the option of therapeutic use, like embolization of the bleeding vessel. Okay, whereas the CT angiogram, which is commonly done these days, is much easier, non-invasive, and easily available in most hospitals. Another new investigation is VCE, video capsule endoscopy, okay, which involves the ingestion of a video capsule containing video and other recording mechanisms, so that it can take videos and pictures of the gastrointestinal tract as it travels from the mouth to its exit at the anus. I put here the special investigations, which include the video endoscope, angiogram, and RBC scan. These three are not routine investigations for lower GI bleed, but it's done when necessary, depending on the severity of the bleeding. Again, I must emphasize colonoscopy as the mainstay of investigation and treatment. It is not only diagnostic to detect the source of bleeding, it is also therapeutic, as it provides the means for the various endoscopic procedures to stop the bleeding. Okay, this is what the endoscopic picture of a diverticular disease. Okay, the diverticulum occurs on the left side of the colon. The sigmoid is the most common site, and the descending colon. Together, they're more than 2/3 of the diverticular disease are confined to this area. Acquired diseases which are out sigmoid colon due to aging process. You will see the openings of this diverticula. Here, colonoscope picture showing multiple openings in the mouth of the diverticulum. Okay, the bleeding occurs within this diverticulum, in the dome of the diverticulum. Okay, this is a schematic representation of what a colonic diverticula is all about. It's an outpouching of the wall of the intestine, large intestine, through weak points in the wall of the large intestine. Okay, and these outpouches are peculiar in that they do not contain the full thickness of the muscle layer. There's no muscle layer covering that. As such, the blood vessels that enter to feed the intestine are exposed to erosions and other destructive air forces, and causing hemorrhage and bleeding. Okay, you can see here the muscle layer, muscularis here, stops short, and where the diverticulum forms, this is the mouth of the diverticulum, this is the dome of the diverticulum. The blood vessel that's supplying it has been stretched out, and as a result, easily eroded by the diseases or the processes that take place within the lumen of the diverticulum. Okay, here is a colonoscopic picture of a bleeding diverticulum. It's the ostia or mouth to which the blood oozes out. Here it shows multiple diverticula in the colon which have stopped bleeding. Okay, you see here, stop bleeding. Here also has stopped bleeding. So these are pictures of bleeding diverticulum. Okay, these are pictures of angiodysplasia, which are actually venous or capillary ectasias in the wall of the large intestine. Okay, here there's a small angiodysplasia, and over here it is a much larger and more complicated angiodysplasia. This occurs commonly in the right side of the colon, in the cecum, and especially your ascending colon. These again are prone to bleeding due to erosions and corrosive actions within the lumen of the colon. Okay, this is a picture of a malignant lesion, the colon, carcinoma of the colon that is ulcerated and bleeding. Okay, it's a malignant bleeding ulcer of the colon. These are another two pictures showing here another carcinoma of the colon, which just got bleeding. See, you can see some blood stains, and over here is a malignant polyp, also evidence of recent bleed here. Okay, polyp. This is a CT scan film, CT angiogram film of a patient with lower GI bleed, where there's extravasation of contrast into the lumen of the descending colon. Okay, the arrow shows to that here. That means there has been some bleeding in this part of the colon. Here again, you see the arrow showing you extravasation of contrast into the lumen of the descending colon, which is a sign of bleeding in that area. Okay, this is another film, CT scan showing you CT scan angiogram is showing you bleeding into the lumen of the colon. Okay, next we come to mesenteric angiography. Mesenteric angiography, in this procedure, the bleeding rate of 0.1 to 1 ml per minute can be detected. And so you need a minimum blood loss at this rate for it to be detected on an angiogram. Selective angiography is done by catheterizing the arteries concerned selectively under the fluoroscope guidance. And these arteries are the superior mesenteric and inferior mesenteric. And this therapeutic is also therapeutic by embolizing the bleeding vessel. Okay, here this is a inferior mesenteric artery supplying the descending colon here, descending and sigmoid colon. Here, black substance here, and this is a contrast that is leaked into the lumen of the descending colon, indicating the possible site of bleeding in this patient. Okay, this is known as the catheter angiogram, where a catheter is passed into the duodenum, into the aorta, and cannulating the SMA or the IMA, whichever the need may be. Okay, this is a SMA angiogram. Okay, to cut the superior mesenteric artery is cannulated and the dye injected, and you can see a leakage, the extravasation or leakage of dye in the right side. Okay, in the ileocholic artery. So you know the site of bleeding is in the cecum or descending colon. This shows you a RBC scan. Tagged RBC are injected into the patient, and then scan done over the abdomen. Okay, and then you see there is a extravasation of this tagged RBC in the right ilia fossa region here. Okay, this is the ilia arteries, and this is the aorta. Okay, so here that means you know there is some extravasation, indicating there's some bleeding in the ilia fossa region, most commonly in the cecum or the descending colon. Okay, this is another view of the same extravasation or leakage. Okay, here again it shows you another leakage of the RBC, tagged RBC, lower down, probably the sigmoid colon or even rectum. Okay, just a summary of these three special investigations of lower gastrointestinal hemorrhage. Colonoscopy is the most important that must be done within 12 hours in stable patients without large amount of bleeding. So stabilize the patient and proceed with colonoscopy. Selective visceral angiography needs 0.5 mils per minute of bleeding in order to be positive. It is sensitive, 40 to 75% sensitive, if the bleeding is occurring at the time of the examination. Tagged RBC scan can detect bleeding at 0.1 mils per minute. Therefore, it is more sensitive than your angiogram. Okay, 85% sensitive if the bleeding continues at the time of examination. The drawback of tagged RBC, although it's very sensitive, the drawback is it's not accurate in defining the left versus the right colon. So that causes some confusion as to the localization of the source of bleeding. The last special investigation is VCE, video capsule endoscopy. This is done by a fasting patient swallowing a capsule. Okay, a capsule which is made up of these components: a camera unit, a lens, camera lens, light source, microchip, and batteries, and also a transmitter. So this capsule traverses the length of the gastrointestinal tract from mouth to the anus, and as it does so, it takes pictures and videos as it traverses the length of the gastrointestinal tract. And these images are transmitted on recording devices which are strapped to the patient. So thousands of images are usually transmitted to this recording device, which are then downloaded and analyzed to see any abnormalities that was detected. The capsule is finally naturally excreted. This is a very interesting and effective mechanism, but the problem is it is costly, not easily available, and also it takes time for the analyzing the images, the thousands of images that are recorded in this capsule. Therefore, this is not very ideal for patients with massive bleeding, but it is very useful for patients with slow recurrent bleeding on the lower GI tract. Okay, these are the various components of the contents of the capsule: image sensor, batteries, antenna, transmitter, radio frequency transmitter, a magnetic strip, and also LED lights. These are the various marketed capsules that are available in the market today. Okay, this is what happens after the patient ingests or swallows the capsule. It travels throughout the intestine and finally ends up in the descending colon or sigmoid colon here before being excreted. And these are the images transmitted by the capsule to the recording device, which need to be analyzed by experts so as to diagnose any abnormalities that may be conveyed. Okay, once this has been done, examination has been, investigations are done, and diagnosis established, then you need to clinically assess the patient for further treatment. Okay, this is done through a good history, recording the amount of bleeding, length, duration of bleeding, and also symptoms of severe blood loss like tired, giddiness, and breathlessness. Then a thorough examination is necessary to evaluate the mental status, pallor, lethargy, breathless, and cyanosis. The BP, pulse, and the cold clammy extremities are important indicators of the severity of the bleeding. Other parameters include the blood tests like hemoglobin, renal and liver function tests, ABG, and chest X-ray. And also it's important to get details of the premorbid conditions of the patient, medical illnesses he or she has got, and the drugs, especially anticoagulants, that he may be taking every day. The Glasgow Blatchford score and the Rockall score, the first for need for the intervention and second for the prognosis, are also important scores used for upper GI bleeding assessment, which again can also be used reapplied for lower GIT bleed as well. Once you assess the patient's severity, you can classify the severity into mild, moderate, and severe. Next, we come to the management of lower GI bleeding. First, resuscitation. As in all cases of bleeding, initial treatment is resuscitation. Replacement of IV fluids and electrolytes. Sometimes may have to give crystalloids, colloids like Hamacel or dextrans, especially for those with signs of shock. Blood transfusion is a very important part of the initial treatment. If there are indications for blood transfusion like severe anemia, hypotension, and impending shock, then I think blood transfusion is warranted urgently. Supportive treatment of nasal oxygen, nasogastric tube to aspirate the blood, whatever blood that is being in the stomach, and urinary catheter with input-output chart. H2U or ICU monitoring closely the pulse, BP, and oxygen saturation. If the BP is low and is hypovolemic, and central venous pressure monitoring may be necessary. Next, we come to the definitive treatment. Definitive treatment is endoscopy. These patients must be subjected to endoscopy, and the rest of the findings depend on the endoscopy. Endoscopy not only diagnoses the condition, it will also to help into the treatment or to stop the bleeding, such as using ligation, application of clips, endo clips, cautery or heat probe to cauterize the bleeding vessels, or use of injection adrenaline to cause vasospasm and stop bleeding. Angiogram is another possibility. If there is need for angiogram, this can be done, and at the same time embolize the bleeding vessels to stop the bleeding. If these are not available or are unable to stop the bleeding, then you go for surgery. Usually open exploration to identify localize the area of bleeding, and then follow up with segmental resection of the segment that is bleeding, of the colon that is bleeding, and if not necessary, if unable to find the source of bleeding, then a total colectomy may have to be done to save life. Hartmann's procedure with temporary end colostomy is another possibility for emergency cases. Okay, these are some of the pictures to show you the endoscopic procedures. The application of endo clips here, you can see here and here. Okay, so they apply clips around the base of the diverticulum to clip the vessels. Okay, this is how it's happened. This is the base or the fundus of the diverticulum where there's a bleeding vessel. So this can be clipped on either side to stop bleeding. This is injection of adrenaline. Here we have given one injection here. One site has been injected. Another site is being prepared to be injected. So adrenaline injected at the base of the bases of the bleeding diverticulum will stop further bleeding. And this is angiodysplasias, and this dilated veins which can be cauterized. Best way, easiest is to cauterize and stop the bleeding. Okay, heat coagulation or cautery to stop the bleeding. And if it is a bleeding polyp, then endoscopic, colonoscopic polypectomy will be a ideal choice. Okay. This is how polypectomy is done. This is known as a snare, which is a loop around the base of the pedicle of the polyp, which is then snared. The snare is tightened to cause ischemia, and then it is using cautery, it is transected. So the polyp is removed. So this is known as endoscopic polypectomy using the snare technique. Surgery for lower GI bleeding, segmental resection of the bowel. That means you remove the part of the bowel, segment of the bowel where the bleeder is, okay, so thereby removing the source of bleeding. If it is a small bowel, you can go for resection of the small bowel. If it's a large bowel, you go for some form of colectomy, hemicolectomy or total colectomy. Again, removing the segment that contains the bleeding vessel. And the other one which I mentioned, Hartmann's procedure, especially used for emergency, where the rectosigmoid is removed, rectosigmoidectomy plus temporary colostomy. This is your Hartmann's procedure. Okay, this is the rectal stump, this is the descending colon, and here rectosigmoid colon has been removed, resected, and the section and the resected segment is removed. Thereby, the bleeding is controlled. After controlling the bleeding, then what we do is you close up the anorectal stump here, which is the stump B here, rectal stump, and leave it. And then the end A, which is the end of the descending colon, is then brought out as a temporary end colostomy. Okay, so Hartmann procedure is the resection of the rectosigmoid colon with closure of the anorectal stump and formation of an end colostomy by the descending colon. This is, then you wait for a couple of weeks or a couple of months until the patient is stabilized and there's proper healing and the area of resection is healed. Then you go back and undo the colostomy and rejoin with the rectal stump, thereby establishing continuity. Hartmann's procedure. Okay, this is a diagrammatic view of Hartmann's procedure. This is the rectosigmoid colon, which has been removed. The anorectal stump is sutured and left behind. And your descending colon, the end of the descending colon, some stump C, is then brought out as a colostomy.
Okay, this is a summarized flowchart lower gastrointestinal bleeding. It is divided into 4 stages. First stage is assessment, second stage is endoscopy, third stage is the other investigations, and the fourth stage is surgery or interventional treatment. Okay, first, when the patient comes in, you classify the patient into mild bleeding, moderate bleeding, and severe bleeding. And in most mild cases, or moderate case and some moderate cases, the bleeding usually stops spontaneously. So in these patients, you can do a colonoscopy, prepared colonoscopy as soon as possible. If any positive findings, then you decide on the treatment, whether endoscopic treatment or open surgical procedures. If the colonoscopy is negative, then you may do for other investigations, such as RBC TAC scan and a video capsular endoscopy, and then decide whether you need to do surgery. Okay. In patients who come with severe bleeding and the bleeding does not stop, then this poses a real emergency. So in these patients, you may not have the time to do a colonoscopy. So what you do is straight away go for a CT angiogram and find out where is the source of bleeding. If it is positive, you may want to consider intravenous vasopressin infusion, or if you have the facilities, you may continue with embolization of the bleeding artery. If, however, it is negative, if the angiogram is negative, then you may have to go for emergency intraoperative colonoscope, where the patient is taken to OT and an intraoperative colonoscope done to see from where the bleeding comes, and then you may go for either segmental or total colectomy. Okay, this chart is a very simplified version of the management of a patient with lower GI bleeding.
Okay, do the question. Just now we forgot to do two other questions. Okay, so we do this. This is the last slide. Okay, can
Announce a second question.
we start another. Means got three more lah. 2, 3, 4.
Yeah. 54-year-old woman present with blood stain stool for the last 2 weeks. It usually comes after defecation and is painless. Clinically, she is well. The most useful investigation for her is video capsule endoscopy, colonoscopy, CT angiogram, barium enema.
Okay, 30 seconds from now. So this patient is not so, is quite stable, she's quite well. Okay, so I think you're right, 91% of you said colonoscopy. So this patient is quite well, so you don't need to do anything that urgently. So you can prepare the bowel and do the colonoscopy the next day or as soon as possible. Alright. Whereas the angiogram is usually done as an emergency, where the patient is very severely bleeding and is not fit for colonoscopy. Video capsule endoscopy, as I told you, as I said in the talk just now, it is only done for elective case because it takes time. Okay, so you have to analyze to get the result. So it's more for elective case, chronic GI bleeding. And barium enema used to be a very important examination, but nowadays it's very rarely done because of colonoscopy. Okay, nowadays barium enema is becoming less and less important. But next time you are working in some place where a small place, you got no choice, you may have to do barium enema. Okay, next, we go to the next question. Okay, come.
The following are used for the evaluation of a patient with rectal bleeding, except blood pressure, heart rate, hematocrit level, radionuclide scanning, pulse volume.
Okay, this one I don't think you need 30 seconds fast. Okay, so in fact all are right, all the things I use right. So it is clinical and radionuclide scanning. I think maybe you didn't understand the question. Actually they accept the one is radionuclide, so I think most of you got the answer wrong. Actually they wanted, it is supposed to be the clinical evaluation. I think I missed out the word clinical evaluation. So if it is clinical evaluation, then you want to see severity, blood pressure, heart rate, hematocrit level, HB, as well as pulse volume. Right? Okay, I think, okay, next one, the last one, polling number 4.
Common procedure is invasive lower GI bleeding, involve the segmental resection of the rectal sigmoid colon, always followed by a permanent colostomy. Primary end-to-end colorectal anastomosis is done to establish bowel continuity. Angiodysplasia of the sigmoid colon is the most common cause of the bleeding.
Okay, 30 seconds. I just told all this about Hartmann's procedure. Okay, so the answer I think is right. All of you all, most of you all got the answer right. Involves is a rectal sigmoidectomy, removing the rectum, upper part of the rectum and the sigmoid, because it is usually is due to diverticulum bleeding in the sigmoid colon. So you have to remove the sigmoid plus upper part of the rectum, alright, and then you join back the descending colon. But in this case, it's an emergency procedure. We dare not join it back because once if emergency you join back, high rate of breakdown. So what you do is do a temporary colostomy. I told you few weeks or few months, sometimes 1-2 months depending on the patient, how fit he is, then you go and join it back. It's called Hartmann's procedure. Okay, primary end-to-end anastomosis is not done. Okay, so if you do that, you straight tell them you will do that, means you straight fail. Alright, angiodysplasia, the sigmoid colon is the most common cause. No. Okay, angiodysplasia is the most common cause in the ascending colon, right side. In the left side is diverticular disease. Okay, and diverticular disease is more commonly seen than angiodysplasia. Okay, I think that's all. We stop that. Okay, any questions? Now we come to the clinical case. I think I'll send you all the clinical case.
Now let's go through a short clinical case to demonstrate this lower GI bleeding. A 78-year-old man was admitted for PR bleeding for 1 day. He passed out large amount of bright red blood with clots, after which he felt very weak and dizzy. There is no history of pain or altered bowel habits, and the patient has never had a history of passing blood-stained stool or melena. He is a case of hypertension and suffered a stroke 2 years ago and is on Plavix 75 milligrams since then. On examination, he was quite comfortable, but the BP was 100 was low, 100 by 60 millimeters of mercury. Pulse rate was slightly high, 100 per minute, and the volume was poor. The arterial oxygen saturation was 96% on room air. The patient otherwise was alert and comfortable, and there was mild pallor. The abdomen was soft but not distended. There was mild tenderness and guarding at the left lower quadrant. Otherwise, it was normal. Rectal examination revealed large amounts of fresh blood with clots, and proctoscopy was not useful due to poor visibility.
Okay, so as usual, the first thing is diagnosis. Okay, so what do you think is the diagnosis? Anybody in this patient? Tivashini?
Yes, doctor. A lower GI bleeding secondary to the long-term use of Plavix.
You think it's due to the Plavix? Plavix is a antiplatelet. It can cause promote coagulation problem. What do you think in this patient?
It could be.
These are the clinical summary. So, looking with this clinical summary, you must come to a provisional diagnosis. So, what is a clinical provisional diagnosis?
Diverticulitis, doctor.
Good. So, this, as I said, age of the patient 78. Okay, it's old elderly patient. So, the two common things in that age will be diverticular disease and angiodysplasia. Okay, so these are the two. And between the two, diverticulitis is more common. And then sudden history of bleeding and large quantity of blood until he felt dizzy and weak. Now, and then the important thing is he's taking Plavix, which is an antiplatelet agent, which can make the bleeding worse. Okay, so if we cannot find any cause for this bleeding, then you think of antiplatelet as the cause. So in this patient, you must look for a cause. And then when you examine, he is pale, slightly pale, tenderness and guarding at the left iliac fossa. So they use something going on in the left iliac fossa region. And what's the most common thing that can take place in the left iliac fossa? Is diverticular disease, diverticulitis and its bleeding. Alright. The bleeding is fresh blood and clots. Okay, what does that mean? Tan Bing Jia? Mei Hui? What is the tenderness and fresh blood and clots? What do you think is the importance of that? Janisha? Now we go to Tan Kaki. What do you think? Not Tan Di Kaki, sorry. Sorry.
I'm not sure, doctor.
Fresh blood means, that means one is very large amount. If it's coming from above, it must be very large amount. The other important thing when you say fresh blood, bright red, is arterial bleeding. And I told you just now, you look at the diverticulum, it bleeds from the artery at the base of the diverticulum. So it's arterial bleeding, and in fresh with clots, that means it must be from the lower GI tract. Okay, unlikely to be upper GI tract. Unlikely to be even cecum and ascending colon. So it's something occurring in the left side of the colon. And the most common on the left side, or in case in general, it is diverticular disease. Okay, so that more or less localizes gives you, is not very accurate, but clinically you can say, oh, this must be from the lower part of this thing. So diverticular disease is more common. Whereas angiodysplasia is in the cecum and right side of the colon. So if bleeding from there, and angiodysplasia is bleeding from the vein. It's a venous bleed. You don't get bright red, it will be dark red in color, altered blood. Okay, just now the first few slides I show you, Melanix 2, fresh, they call it fresh melena. So if we come from the cecum or ascending colon, it is usually not bright red in color. If it is bright red in color, it's usually arterial blood, and the most common arterial bleeding is diverticular bleeding. Okay, and then how will you classify this patient now? From this clinically, okay, mild, moderate, or severe bleeding? Kake, what do you think?
Severe.
Severe, you think severe, why? This is very important. You are the patient, you are the doctor, let's say admitting the emergency doctor. So when the patient comes to you, they'll try do the triage. So you are the one supposed to be doing it. Decide whether this patient is severe, moderate, or mild. Then you decide what to do next. Okay. So what do you think? Why do you think it's severe?
Because the patient is already in hypotension and tachycardic.
Okay. And the feeble pulse also very feeble and not so strong. So very good, important. That's right. So important thing is once they get blood pressure, his blood pressure 100/60. It is not to say low, very low, but it is low. For his age, it is still low. Okay, maybe he's a known hypertensive patient. Maybe that you must find out from the patient in the history. Normally, what is his normal blood pressure? Normally, his blood pressure is 150/80. And now he comes 100/60 and he's pale and he's tachycardic, then it is very significant. That means there's been a lot of pressure has dropped significantly. Alright? And tachycardia 100 is is high and feeble. These are the words that they use. Okay. So looking at this clinical picture, I would say is from bleeding diverticular disease. Alright? And the others, angiodysplasia. The other important thing in old patient, you must always think CA colon. These are the three things in elderly patient who come with large amount of PR bleeding, fresh bleeding. Diverticular disease, angiodysplasia, CA colon. All the others can occur, which I say radiation, colitis and all that, but they don't come with so severe bleedings like this patient. Okay, so I agree with you. The other thing is to evaluates, I would evaluate as moderate. Okay, maybe he can either in the moderate, if he may stop bleeding, he may become mild, or he can continue bleed, he can become worse, severe. I feel the BP and the tachycardia is due to the hypovolemia, so it's going into severe. I would say moderate or even severe. Also, if you say you are not wrong. It's better to be on the higher side. Better to overestimate him than to underestimate. You say, hey, this one mild, and then you leave him alone, then he may bleed and it's too late to do anything. So it's better to always overestimate his condition. If you take him as more seriously, it's better for the patient. Okay, so I agree with you. If you say serious, okay, I would say moderate lah. That means it's in the critical thing. You can either become better or you can become worse. Become better, no problem. It's good for everybody. Become worse, and then in this age group, it's the old case of stroke. Then you can patient can collapse and die. Okay. Any question? Then I just give you these 3 short questions, and that will be the end. Any questions or not before you all undergo? So what is the most likely diagnosis? Let's see if we take who? Janisha? Janisha is not there. Where you went?
Yes, doctor.
Okay, what do you think? And you should know this answer, no problem.
Bleeding diverticulitis.
Okay. Okay, so if you want to complete the thing, it's bleeding diverticular of the colon, diverticular disease of the colon, bleeding colonic diverticulum. If you want, you can even say patient with hypotension. Okay, that means he can go into shock anytime. Okay, that means severity. But this is what we need. Okay, next one. Anybody wants to take? Nicole, you want to try?
Yeah. The Glasgow-Batchmore score and the Rockwood score.
Okay. So how in this patient, using that, what do you think? What are the things? First of all, what are the things you say? You say clinical first, So what are the parameters in this score that you are looking for?
The hemoglobin level.
Okay.
Also the blood pressure, pulse, and urea. And then for the Rockwood score, we look at the patient age.
Yes. Okay.
Yeah, any comorbidity.
Okay. Good.
And endoscopic evidence of bleeding.
Okay. So okay. So these are important thing. Age is important. Age. Okay. Very easy to say this. You must know the score and what the score. What are the factors they take into this score? Age is important. Old. This patient is 78, so he's considered very old. Old history of stroke, and he's taking Plavix. All these make it very high risk patient. And secondly, clinically, when he comes, you assess his BP, his pulse, his oxygen saturation, whether there's evidence of continued bleeding. When you check him, you do a rectal examination or proctoscopy, see whether he's still bleeding or the bleeding has stopped. Okay, these are important. So in this patient, if most of the times the bleeding stops in the large majority of cases, if it stops, then you give blood, the patient will improve. All right. Then the other important thing is hemoglobin and ACT, hematocrit or packed cell volume. Between these two, ACT is more useful because HB takes more than a day, nearly half a day or two, fall, unless he bleeds very fast. If he's bleeding slowly, the HB will fall very slowly. So the HB may be normal, but the patient is bleeding now. So this hematocrit is the first thing to drop when the patient bleeds. Then your Glasgow-Blatchford score and Rockhouse score, which I covered in the earlier lecture today. And using these things, you classify the patient into mild, moderate, and severe to help you decide how aggressive or how rapidly, urgently you want to institute all the different investigations and treatment. Okay, now we go to Teo Siu Hei, the last one. Year 5 must look at the management.
Outline the principles of subsequent management of this patient. First, depending on the severity of the bleeding.
Okay, in this case, decided is moderate to severe.
Moderate. Maybe I will go for the colonoscopy if the patient can wait for 1 day and no continuous bleeding. If not, I will go for CT angiography.
Okay.
Then first I will resuscitate the patient with IV fluid.
I expect you to say that first. I will resuscitate him. What will you do? Use to resuscitate him?
Crystalloid solution like normal saline.
Okay. What else?
If the blood pressure is still very low, then maybe can consider colloid or even blood transfusion if the
Okay,
he deteriorates.
in this patient, will you give blood transfusion or not?
Not yet.
Not yet. Still want to wait.
You can use colloid first.
Yeah, of course you use colloid. Blood will take some time. So normally what you do is you run normal saline or colloid if you have. Colloid, normal saline is more safer in older patient than colloid. Colloid can cause pulmonary edema, especially old patient with heart problem. So colloid you must be very careful. In fact, better safer to give blood rather than colloid in old patients. So saline is definitely a give. Then of course if the BP drops while waiting for the blood, you have to give colloid, no choice. Okay, and then in this patient, I think I would get some blood ready, and I think I will give because he looks pale. Once he looks pale, that means a significant amount of blood loss. And in elderly patient, if you wait too long, you have to give the blood very slowly. You cannot rush the blood, otherwise you get pulmonary edema. So in younger patient, you can run the blood fast. In case he bleeds, and then his reserves will be very much lower, so he will tend to collapse faster. So I think I would give him at least 1 or 2 pints of blood slowly. If he bleeds more, then of course I'll run the blood faster. Okay. Okay. What else you want to do? Okay, this is the one. Okay, I will blood transfusion, and also most of these patients with bleeding, we also cover under stress to prevent stress ulceration. So we also cover them with PPI infusion, so that once this bleeding stops, and then he gets a stress ulcer and then bleeding from somewhere else, so it becomes, the prognosis becomes worse. Then close monitoring, HDU or ICU, and close monitoring of all the vital signs, saturation, BP, pulse, and also the urine output. Okay, so this first line here is applicable to all cases. Only thing you modify to suit that particular patient. In this patient, if it's a young patient, say it is 30 or 40 something with this vital signs like that, then maybe I may hold on with the blood, just give, and then maybe if he doesn't bleed, he can recover. Give him fluid, the BP will shoot up, so no problem. But in a 78-year-old man with a stroke, you can't can't rush the fluid fast. Okay, so that's the problem. So it's better to give blood rather than the saline or colloids. Okay, what else? Next, investigations. What do you want to do? So first of all, resuscitate. Then only you try to resuscitate. So in this patient, then you do investigation. What will you do?
CT angiography.
CT angiography, okay.
And then find the source of bleeding and send the patient for surgery.
Okay, then?
Since it's a diverticular bleeding, the surgery that can...
We don't know. Maybe CT scan, say for the angiogram, the bleeding must be at least 0.5 mils per minute. Otherwise, it will be negative. So most of the time, the bleeding stops temporarily. You send him, this critical or the typical scenario is the patient bleeds and then you take him to the investigating, take him to the x-ray there, the bleeding stops. And then you inject, you do the angiogram, becomes negative. Then you bring him back to the ward. After a few hours, he bleed again. Then you rush him to the angiography table there, and then he is no more bleeding. So this is a typical situation in this type of bleeding in old people. So what will you do? Okay, if the bleeding continues, I will send for emergency. The most important investigation I told you all in the slides just now is colonoscopy. Upper GI is OGDS, lower GI is colonoscopy. So that's the best investigation that you must do. Okay, so you try to do whether emergency or elective. If the bleeding stops in this patient, then maybe I'll postpone to the next day, give him blood, make him more stable, and then I'll do the scope. If the bleeding continues, you cannot wait the next day, then you have to do an emergency scope. I told you, where you have to do it in OT, and then see whether there's bleeding, and then you see where the site of bleeding. Sometimes it's difficult to see, then you can straight away do the operation. Okay. If the patient is not fit for colonoscopy, let's say the BP drops, patient is drowsy, then you dare not take him, you can't go and do a colonoscopy on this patient, he will die on your table. Then you may want to do a RBC scan also. Most places they don't have the RBC scan because it involves radioactive material. So you do a CT angiogram. If in places where they can do the catheter angiogram, then they can use embolization at the same time. So in most centers, you do emergency colonoscopy or CT angiogram. Nowadays, CT angiogram is done in many hospitals. And then decide whether need to do emergency surgery or treat conservatively. Okay. If the bleeding stops, which is fortunately that is the most common scenario, I think 70–80% of the bleeding will stop. You give blood, then you run giving PPI, all these things, the bleeding will temporarily stop. Then you got time to do your colonoscopy as soon as possible. And then if the bleeding, you do colonoscopy, cannot find any cause, then maybe it's elective, you can prepare for VCE, video capsular endoscopy. Okay? Okay, Teo? So, it's a very common question format. Outline the principles of management. So, this is you must follow a standard practice, standard answer. 1. Resuscitation. Resuscitation is always fluid, blood, oxygen, and then monitoring. Okay, so giving fluids, monitoring, and giving certain drugs, which is important. If it is bleeding ulcer, you have to give IV PPI immediately. But in this case, PPI is only to prevent something. Is not so you don't give as a first line. You can wait until it's stable. Also, you can give, no problem. Okay. So fluid resuscitation and then monitoring. These are the two things: fluid and monitoring, and maybe oxygen. Then ICU setting or HDU setting. So these are the 4 things that you must mention in resuscitation. Okay. Then after that, subsequent management is investigation. Okay. Investigation in most of the time is a scope. Okay. In this case is colonoscope. You want to do a scope. So whether it is emergency or can wait one day or 2 days and make the patient more stable, depends on the condition of the patient. Alright. Of course, severe bleeding you cannot wait. If it is mild to moderate, which I show in the algorithm, mild to moderate, maybe with some resuscitation, patient will be better. You can do the next day. Patient is more stable. I think that will be the ideal thing. Otherwise, you take him to emergency in OT and all, very, very high mortality rate. Okay. So this is resuscitation. After that, investigation. After investigation, then the treatment comes. So most of the time nowadays we try to do endoscopic treatment, clipping, cautery, ligation, this sort of thing. And if these don't work, then we have to open up for open surgery. Okay, any question? So I've covered, so in this case, this is the summary. What is your learning objective? Causes of LGIB, clinical presentation, investigation. Colonoscopy is the focus of all the investigations, or whether you need the more complex investigations, okay, sophisticated investigations. Then management. Management again, outline of management means resuscitation, monitoring, and then investigation followed by treatment. Then this is where you can go back and read up on today. And for you all, better to go back and read up the details of colonoscopy. How is colonoscopy done and all that.